Very warm good evening to all of you. So it's 8:30 and our grand rounds, as promised, every month, the last Friday, we are going to we are coming up with another grand rounds, Vertigo grand rounds, where we take one case or maximum two cases and then go deep into discussing it, some challenging cases. So today's case presentation is by Dr. Sandeep Sharma. Okay. So we will be he'll be presenting the case, and then it is going to be followed by a panel discussion with an eminent panel with Dr. Dhanya and Dr. Abhik. Let me introduce the panelists. The case presenter, who is Dr. Sandeep Sharma. He has more than 20 years of experience in ENT, around 8 years of experience in neurotology itself. Has taken more than 50 workshops in vertigo and vestibular rehabilitation. Okay, he practices in Ludhiana, and he gets a lot of referral patients from across the region and from elsewhere also. So, and he's a very passionate neurotologist. Okay, that is what I can say about him. Then we have Dr. Dhanya, who is an MBBS and DLO from Calicut Medical College and DNB from Medical Trust Hospital, Cochin. Currently, she is working as a senior consultant ENT at Rajgiri Hospital, Cochin. She's been the ex-secretary and ex-vice president of Association of Otolaryngologists of India of the Cochin branch. She is the recipient of Dr. Krishnadas Memorial Gold Medal for the best PG paper presentation. Now, our next panelist is Dr. Abhik Sikdar. Dr. Abhik Sikdar completed his MBBS in 1997 from Calcutta National Medical College and MS ENT from Mahatma Gandhi Memorial Medical College, Indore. Okay. He joined Chaitram Hospital, where he presently also is a senior ENT consultant in 2010. And he's been accepted as the member of the National Board of Medical Sciences, MNAMS. And of course, he's completed the Assessment and Management of Vestibular Disorders course. He's have multiple awards from ranging from PG quiz at the All India conference level to first prize in endoscopic workshop, cadaveric dissections, Stores Endoscope Awards, best temporal bone dissector, in the workshops that are conducted by Dr. KP Morvani, and runners up in the video awards in the Kolkata AOICon. He has a huge number of publications which relate to endoscopic removal of malignant melanoma, two-handed approach to bronchial foreign body, like that, in a variety of range of subjects in journals of international repute. So that is Dr. Abhik for you. Okay. So now I will proceed with the playing the case presentation. Okay. Dr. Sandeep Sharma will be with us, but then the presentation itself of the case is a recorded presentation. Okay. So he is because he's little in outside, so he cannot have his laptop for presentation. So he recorded the case presentation and gave it to us. I'll play that presentation first. This is going to be the format. Then we'll take up some questions. The presentation of the case itself is two parts. One is Dr. Sandeep Sharma is posing some questions. The panelists will take those questions and try to answer those questions. and then it is going to be followed by what exactly happened with the patient, second part of the case presentation. So I will start playing that.
Good evening, friends. This is 50-year-old male presented with 2 days history of position.
The audio is not audible. Dr. Srinivas, the audio is not audible.
Dr. Abhik, you are saying something.
The audio is not audible.
Okay, let me check. Abhishek? Hello?
Yes, sir.
Audio was not audible to anyone, or it is only for sir?
Sir, before this, audio was audible. Now I can.
No, now I have paused it. Now I have paused it. No, now I have paused the video. When I started playing, was it audible? Audio was not audible. I will start again. Just see that. Okay.
Good evening, friends.
Can you?
This is 50-year-old male.
Yes, can hear, can hear.
Can you hear?
Now we can hear.
Okay, okay, fine.
Of positional vertigo on getting up and lying down, but strangely, his nystagmus, his vertigo will disappear when he used to take turns either to right or to left. And each attack of this positional vertigo will last for less than 1 minute. So out of my, this is the patient giving history, and in such patients, in my routine examination, when I did the Romberg, after around 22 seconds, this patient himself pointed that he has a tendency to fall to right side. And then to make it all more clear, I did the modified Romberg. And as soon as he closes his eyes, he has a tendency to fall to right, and here he goes, here he goes. So his modified Romberg was positive with a tendency to fall to right. So I went ahead with BNG. There was no spontaneous nystagmus in light or in dark, but his hyperventilation was strongly positive with persistent left beat nystagmus. His subjective visual vertical was also deranged with anti-clockwise moving backgrounds. If clockwise moving background, it was just on the edge. He had bidirectional gaze evoked nystagmus with left beating nystagmus on left gaze and right beating nystagmus on right gaze with fixation denied. On Dix-Alpine test right with the head extended, he had the persistent, intense left beat nystagmus. With this slow phase velocity going up to 58 degrees. But this nystagmus was present only in extension, and as soon as the patient was made to sit, his nystagmus disappeared. His Dix-Alpine test on the left side had a consistent right beat horizontal nystagmus. So from Dix-Alpine test, it looked like the nystagmus of the apogeotropic lateral canal variety. So next I did the Boolean test, and on going the head down, there was no nystagmus. Similar was the case in when the head was extended backwards. So Boolean test was strangely negative, which should usually be positive in such cases. But this wonderful thing happened when the patient was made to lie supine from sitting position. He again had persistent, severe left beat nystagmus with slow phase velocity going up to 60 degrees. Now you can see the persistent left beat nystagmus on sit to supine test. On sit to supine test, if we have the left beat nystagmus, that means either right lateral canal geotropic or left lateral canal apogeotropic. But he had this mild downbeat nystagmus of also present along. And this downbeat nystagmus, after some time, it became silent. It became quiescent for some time. And then here in this shot, it is silent at around 3 minutes or so, only to get replaced by this upbeat nystagmus after some time. So this was vertical, positional, periodic, alternating nystagmus. A very strange thing to see in such a case. On right lateral test, there was persistent left beat nystagmus with downbeat nystagmus here at around 34 seconds, becoming quiescent and then becoming upbeat nystagmus for a short while at 64, 66 seconds, only to again become left beat nystagmus. Again vertical, persistent, again vertical, positional, periodic, alternating. On left lateral test, we have the persistent right beat nystagmus, again with prominent downbeat, becoming mildly upbeat later. So with these findings, and there was one very strange thing which we noticed, that patient had severe symptoms when he was made to lie supine from sitting position. But when he took turns to either left or right, although we could record the nystagmus, and that too of like 42 degrees or surface velocity, prominent nystagmus, but patient didn't complain of any vertigo during the sideline position. So now this is all the findings I had. If we sum up the findings, he had atypical history, that nystagmus is more, vertigo is more on lying down and it disappears on taking turns. His rhombus was positive. He had deranged subjective visual vertical with moving grounds. The hyperventilation was strongly positive. He had bidirectional gaze-evoked nystagmus. He had the symptoms which were much more on lying down and they disappeared on taking turns. He had vertical periodic alternating nystagmus in certain specific positions of the head. With all these things, I was confused whether it is a case of peripheral lateral canal, left lateral canal apogeotropic variety, or we are dealing with something else. So it is now up to the panelists to decide what should have been done in such a case and what all these findings lead us to with both peripheral and central. Thank you.
Yes. May I request Dr. Abik and Dr. Dhanya? So one after the other. Dr. Abik, so what do you make of this case so far? Hello? Hello?
Can you hear me now?
Yeah, I can hear you. We can hear you.
Yeah. So basically what I get to understand is that it's an atypical VNG which is coming. And we are not sure whether it's a central or a peripheral cause. But if I look at it, the first thing which comes to my mind with such an atypical feature is it may be a migraine-associated vertigo. Why so? Because here there's a positional nystagmus, but it does not follow any pattern. And the subjective visual vertical is also deranged. It is deranged in case to the right, in case of clockwise, and to the left in case of anti-clockwise. So I would be thinking of a migraine-associated vertigo, but the only problem which is against this is that in a migraine-associated vertigo, the vertigo should have been around 5 minutes. Here it is around less than a minute, and there should be at least 5 episodes. I'm not getting the 5 episodes. So that is what is against migraine-associated vertigo. The other part is that when I'm checking the nystagmus, it is usually a left beating, both on the left side, center, up and down. Only on the right side is there a right beating gaze evoked. So maybe we could have checked it once more. So my first DD would be a migraine-associated vertigo. My second would be a apogeotropic lateral carinal variant.
Yeah. So the comment that you're making is, of course, there has been a right gaze, right beating, left gaze, left beating. That is there. Okay. Then positional variation in the sense on the right, there is a right beating. On the left, there is a left beating. But in the straight supine position, it is again a left beating nystagmus.
Yes. Also up and down, it is left beating. Only on the right side, it is right beating.
Up and down, you mean in the
gaze evoked up and down, also it has some left beating.
Okay. That is in the pseudo-spontaneous nystagmus.
Yes,
has continued to be.
yes,
Pseudo-spontaneous nystagmus is left beating if we consider it as pseudo-spontaneous, or it can be simply spontaneous also.
Agreed.
So that is left beating. And then the nystagmus direction changes both with position change and also with the gaze change.
Right.
Okay. So on that. Then the other pattern which Dr. Sandeep Sharma showed was that this particular patient had a hyperventilation induced exacerbation of the nystagmus. The moment hyperventilation was done, the nystagmus exacerbated like anything. That was one more thing that he told. One more very important point that he told is this patient is symptomatic on lying supine straight, but not symptomatic on turning to the right and turning to the left. He is not that symptomatic on turning to, in spite of the nystagmus being present, So going by whatever has been taught in textbooks, what would you do? Will you label it as a benign paroxysmal positional vertigo, the peripheral variety, or would you think more in terms of a central cause in this particular patient with all these things? Dr. Dhanya? Dr. Abhik, we are not hearing you. We are not hearing you.
To come to diagnosis, sir, am I audible, sir?
Okay, ma'am.
So we will see the patient as a whole. He's a 50-year-old male presenting with 2-day history, and he gives a complaint of recurrent positional vertigo, and that is lasting 1 minute. So when you hear the history, the differential diagnosis which come to our mind is it can be a recurrent first episode of recurrent BPPV. Vestibular migraine, first episode of Meniere's, all these things come to our mind. Since he's an elderly, we will think of first episode, we can think of TA also. And now we come to our examination. So when we do the Romberg, he has a tendency to fall to right. So usually that happens in cerebellar disorders, movement disorders of auto. So we come to think in terms of that. Then we start doing the VNG. In VNG, we are getting 2 central patterns of nystagmus. One is bidirectional gaze evoked nystagmus, but we can see that when the fixation is denied, it is augmented, it is more. And another thing is the periodic alternating nystagmus. These two are considered central pattern of nystagmus.
What about hyperventilation?
So hyperventilation. Classical teaching previously is whenever we see peripheral in hyperventilation, you said it's the horizontal nystagmus. It is a peripheral. It's a persistent left beating nystagmus.
Yeah.
And the thing is, in SVV is influenced by the background. That's a thing which is seen classically in migraine. So putting all these things together, like and the thing what you told is, it's not the typical positional nystagmus we get, because the patient is not having the sensation of vertigo, even though he's having a robust apogeotropic pattern of nystagmus. And the other thing is, in the Bow and Lean test, we are not getting the nystagmus. So definitely we can think about BPPV, but other things, because as we know that vestibular migraine has got a very varying presentation. It can present with different patterns of vertigo. It can present with different nystagmus pattern. And I think even the positional periodic alternating nystagmus, what they mentioned is transient periodic alternating nystagmus can happen in peripheral cases also. So sir, I will go for complete the neurological evaluation by looking for the other signs like this kinesia, tandem walking, the finger nose test, and look for the tongue movement, everything. Then, like since SVV is distorted, it can be a migrainous pattern, and many cases we we are seeing that BPPV is there along with our other like baseline diseases. Like when we have the vestibular migraine, Meniere's overlap syndrome, along with that also the BPPV can happen. It can be secondary to it, or it can be primary BPPV also. So,
yes, sir. Dr. Abhi, yes, sir.
Yes. Here, what I would like to say is that in hyperventilation, the pattern which you are getting, as well as in sharpened rhombus, the pattern which you are getting, both is seen in case of migraine also. Migraine-associated vertigo, both these things are seen.
Yeah. So, at this point of time, my question to both Dr. Abhi and Dr. Dhanya would be, if this patient presented to you, would you first send this patient to an MRI? Would you put the patient on anti-migraine agents? Or would you attempt a maneuver?
Sir, I would attempt repositioning and keep the patient for follow-up, because if patient responds with repositioning, then it's likely to be a BPPV. There's no harm in attempting a repositioning.
And this is despite all the central findings that you are seeing, you would still attempt a BPPV. Is that right?
I would.
You would still attempt a repositioning.
I would.
Dr. Dhanya, what would you do?
yes, there is no harm in attempting repositioning, because last week we had one patient.
Okay.
That is actually the lady had a baseline vestibular migraine Meniere's overlap syndrome, and she was having downbeats. When I examined, it was showing torsion also. So like the first visit, I just like give the medication for the baseline problem.
Okay.
And 2 days later, she was bad and she came back.
Okay.
And then I did the echo, So
okay. Yes.
Second, she improved. So I think even if we are having another baseline disease, if we get the immediate result, immediately after manual.
Hello. Yes.
Yes.
So both of you are in favor of, in spite of so many findings trying to confuse us, so many findings of central patterns that we are seeing, still both of you would attempt a repositioning maneuver either immediately or after a few days. So that is the consensus. Maybe you will keep a close follow-up, whatever it is. Let us see what exactly Dr. Sandeep Sharma did. Okay. And after that, we'll have a more bigger discussion. Okay.
Now, what I did was, in such a patient, thinking of it as, although the central signs were there, thinking of it as peripheral nystagmus, left lateral canal apogeotropic, what I did was, I did the inverted Buffoni for left lateral canal apogeotropic. You will see the inverted Buffoni being done. So inverted Buffoni was done, and this was the result of inverted Buffoni. And when now the patient was made to lie supine from the sitting position, instead of the earlier persistent left feet nystagmus, he had now mild right feet nystagmus, indicating conversion of the apogeotropic variety to geotropic variety. And then on right lateral there was mild right feeding nystagmus, and on left lateral there was intense left feeding nystagmus, indicating the conversion and indicating it to now, indicating that now the left lateral apogeotropic has got converted to left lateral geotropic. I'll also show the video of this being with the GMC goggles on. Now this is the right and this is the left lateral position. And this is the video, and then this is the video of the barbecue roll test now being done. Barbecue roll being done now for this patient. For the left lateral geotropic, which we had converted by converted Buffoni. Now this is the barbecue roll for the converted of the left lateral geotropic after the inverted. Earlier we did the inverted gophony. This was the change from apogeotropic to geotropic. This was the barbecue roll. This was the barbecue roll. Barbecue as I have shown you. This was the result of barbecue roll. With the disappearance of any nystagmus in the sit to supine position and then the left lateral position. This is the video recording of the same. Sit to supine, there is absolutely no nystagmus.
Research, like we are planning to.
On left lateral, there is no nystagmus. So this was correct. So this, although this patient had so many central findings, this turned out to be a case of left lateral apogeotropic. Now, after 2 days, again, I did the BNG of this patient and see, again, there is no nystagmus in light, in dark, and hyperventilation was negative after 2 days. Sit to supine, no nystagmus, right lateral, left lateral, everything was all right. But strangely, subjective visual vertical was now deranged with clockwise moving background. With anti-clockwise, it became all right. I am unable to explain it. Again, it is up to the panelists. The next recording is after 7 days of doing the maneuver. Again, no nystagmus in darkness, hyperventilation negative, big sulfide right, left negative, sit to supine negative, right lateral, left lateral, everything is negative. I'll show you the video of hyperventilation being done after 7 days also. So this was hyperventilation. You can see the recording of after the hyperventilation. I've already shown you the graph. You can also see here the graph. This is the video. Again, I will show you the graph. Hyperventilation. So, how the central signs also disappeared with the correction of left lateral canal apogeotropic variety is beyond my explanation. I leave it to you esteemed panelists to throw some light. Thank you.
So we know what he has done. So as both Dr. Abik and Dr. Danya said, that they would still go ahead with they would still go ahead with the maneuvers. So even Dr. Sandeep Sharma has gone ahead with the maneuver, but found some surprising results that after the maneuver, patient became asymptomatic, number one. And two is, in addition to the patient being asymptomatic, the other things that happened to the patient is that all those central findings, that what you would have considered as, I don't know whether hyperventilation induced nystagmus should be considered central or peripheral, that disappeared. Gaze-evoked nystagmus disappeared, and the spontaneous or pseudo-spontaneous nystagmus disappeared. So what is the explanations that you have to offer, okay, when you see this kind of a normalization of so-called central finding, like the even gaze-evoked nystagmus, that is the typical direction-changing nystagmus. Okay, direction-changing nystagmus on changing position is peripheral, but direction-changing nystagmus without changing position was never considered as peripheral. It was always considered as a central sign. Now, how do we explain each of those things? Okay, who would want to attempt first? Okay, Dr. Abik or Dr. Dhanya, and Dr. Sandeep Sharma also, you can join in, sir. Who would want to have a go at it first? Dr. Abik?
So I would not be able to explain why it has happened, but sometimes what I see is in any nystagmus, if patient does not follow your orders correctly, you get a wrong result. So if I was doing this case, actually there was only one position in things were not fitting. That was when patient was looking to the right in dark. maybe I would have repeated it. But even after repetition, it may have still given the same. I don't have an answer to this. I don't know why, how it has worked that.
Dr. Dania, you want to attempt?
Sir, in some cases of vestibular migraine, when they come, we get all sorts of nystagmus. And when they are improved, when they recover, when the second setting, when we do everything would have vanished.
I will have Dr. Sandeep Sharma to come in and say whether he immediately checked for resolution of symptoms or it is after some time. Dr. Sandeep Sharma? Hello? Sir, you are walking around all the place, but you are not unmuted your mic. You have to unmute yourself. Yeah.
Yes, sir. Yes, sir. I want to say that there is no family or personal history of migraine. That was the first thing I thought people will ask.
Okay, that is okay.
I have the habit of checking the patient immediately after half an hour, after 2 hours, after 2 days, after 7 days, and after 1 month.
So
absolutely no symptom after that.
So the resolution of central findings were immediately after the repositioning.
Yes, sir. Yes, sir.
Okay, ma'am. So if it is migraine, maybe immediately after repositioning, we don't expect a resolution. He says that immediately after repositioning, there has been a resolution.
Sir, there is no family history, personal history, nothing like migraine was there.
Okay, so there is no personal history, there is no family history, and even in that episode also, the recovery of the central findings has been immediately after repositioning maneuver. Patient become asymptomatic,
and he is not the only patient. Maybe definitely one more patient I have, and maybe one more, 2 or 3 patients I have of similar findings of hyperventilation positive. The other was hyperventilation positive. This had the other findings also.
Yeah, hyperventilation positivity in benign paroxysmal positional vertigo is now being recognized, okay, as one as a phenomenon in BPPV, and then it does and especially from your cases, and then there have been a couple of other people. What is happening now is, previously BPPV we never were looking at them with this much of depth. Okay, we were not analyzing them. The moment somebody comes and tell positional, the first thing that we would do is do a positional testing and then do a repositioning maneuver. Patient feels better, we use send off. Okay, the positional vertigo patients being studied before, being studied after, maybe it was not happening all this while, maybe because of instrumentation, maybe because of time or whatever it is. Now we are studying more. Okay, if you ask me for an explanation or whatever, I would say these are opportunities. Okay, opportunities for us to see the role. See what the way the central findings appear, the way the central findings go, disappear. Some of the explanations for the central findings, people were attempting on peripheral stimulations. People have been attempting it using different methods. For example, the demonstration of a leaky neural integrator after unilateral vestibular stimulation has been studied in caloric tests. Okay, that has been studied. So but that is an artificial stimulation that we used to do. Now, possibly with all this kind of newer techniques that become available, we are seeing what is happening to the central mechanisms or the central neural mechanisms in the face of a peripheral insult. Okay, these are opportunities for us. Okay, so any kind of a unilateral insult, maybe that is making the integrator leaky. The insult itself is making it leaky. The leaky integrator is known to happen in vestibular neuritis. It has been demonstrated during caloric tests. This has happened. Probably this is one opportunity where a benign paroxysmal positional vertigo has given us that opportunity to study in the face of a peripheral vestibular asymmetry, that the center actually becomes leaky irrespective of whatever is the cause, whether it is BPPV or whether it is vestibular neuritis. And that could explain the gaze-evoked nystagmus, probably. That is one thing. When it comes to hyperventilation-induced nystagmus, maybe all of us will have to put our heads together and again make some more thinking. Possibly one thing that happens, okay, when we are doing our surgeries, intracranial surgeries, skull-based surgeries, and these kind of things, we do ask our anesthesiologist to indulge in 2 types of strategies. One is the anesthetic Valsalva and the other is the anesthetic hyperventilation. Both of these techniques are either to increase or reduce the intracranial pressure, which we have been using as a method. And we know that the intralabyrinthine spaces also have a connection to the CSF spaces also through the cochlear aqueduct, at least, if not anything, at least through the cochlear aqueduct. Maybe there is some amount of a pressure change happening there, or possibly the pressure change that is happening within the inner ear in the face of hyperventilation, because these are all small chambers, and even the chambers themselves are small, in that a little bit of fluid out and or a fluid in is still significant. Possibly that is the thing that we can think of, which caused the hyperventilation induced enhancement. Okay, so maybe with a little extra pressure or a little less pressure, the effect of the clump was more or less. So that could be the thing. Absolutely no clue as to what is happening is why should the person should have so many symptoms or so severe symptoms in the straight supine position, but absolutely asymptomatic on the right lateral, absolutely asymptomatic on the left lateral. Why should somebody become, in spite of the presence of nystagmus? Okay, what role it is playing? Is it directly related to the gravity related position? May not be. If it was only gravity related position change, nystagmus was there. So what else played a role in reducing the symptoms? Okay, we do come across subjective visual vertical tests being done on patients when one side of the body was being touched. Okay, one side of the body was being touched, in the sense in the right lateral position or the left lateral position, and there are some central lesions in which the subjective visual vertical, which is supposed to alter on one side, does not alter when the person is actually one side of the body is actually, the pressure is applied to one side of the body. These kind of studies have happened. So whether that has a role or it was just the head position, I don't know. I'll have to go deep again, see whether you turned only the head or you turned the entire patient. We don't know. If it was only head, then we'll have to think of something else. Or interactions happening within the inner ear. When we talk about interactions, we talk about sensory, I mean one sensation to another sensation interactions. In terms of motion sickness, we come across interactions between vestibular and eye and proprioceptive. But we also talk about interactions between the semicircular canal and between the semicircular canal itself and the otolith organ, the graviceptive pathways. So when the graviceptive pathways are stimulated simultaneously with the semicircular canal, maybe the perception by the brain is different. So what here, this particular case, when we chose to present this case, the idea is not exactly to be able to answer this, but the idea is actually to open up the possibilities of the deep insights these are likely to give us. Okay, these experiments of nature, which we call, okay, are giving us so much into giving us an opportunity to go deep into understanding the physiology, which actual experiments which you do on animal models or whatever it is don't give so much insight. And this kind of things, when we gain more insight out of these things, as we get more and more patients like this, it is going to benefit the patients, because we are not going to unnecessarily investigate them. We are not going to unnecessarily get scared ourselves. We'll first make an attempt. Okay, it looks like a central finding, but maybe let us wait and watch and then see what is going to happen. So we have seen this before. We have seen a patient who has recovered in spite of these findings. Is less scary than actually coming across this kind of a patient for the first time in our practice. So that will help the community. Okay, the community is all of us together. So that is one more reason why we chose. One is that the opportunity that this provides to understand the physiology, the way peripheral dysfunction actually affects the central functioning. And of course, in fact, there was one more patient which we had presented long ago in a patient with Meniere's disease who had a vertical pendular nystagmus. And after the Meniere's disease vestibular neurectomy, the vertical pendular nystagmus itself disappeared in that particular patient. So these are the things that we have seen before. So the way the peripheral dysfunction actually impacts the central findings is something that these kind of conditions provide us an opportunity to study and go deep. Okay, so if there is anything that more, I know, I'm sure that this is not the completion of this is just the beginning of this kind of cases discussion. So if something you want to add, Dr. Sandeep, Dr. Abik, and Dr. Dhania, please do.
So I would like to follow up this patient, keeping in mind that they may develop other features of migraine on a later date.
Okay. Yes.
Though there is no history at this point of time, he may develop migraine, just like before diabetes, something like pre-diabetes. So maybe this is one of the features that he may go on to develop migraine. So I'd keep a special watch for that.
Okay. Dr. Sandeep, is the patient still on follow-up? Dr. Sandeep Sharma? Okay, by then, Dr. Dhania, your comments. See, Dr. Abik still wants to keep this patient. He wants to be careful. He doesn't want to take a risk with this patient. I agree with that. I completely agree with that this patient, in spite of all these things. And then for 1 year, he doesn't have any other problems. That gives us more credence to what we are thinking right now, and gives us more credence to like the thinking that peripheral dysfunction can actually cause central, peripheral abnormalities can actually cause central findings. Dr. Dhania?
Yes, sir. It's a new insight that peripheral disorders can cause central findings. So
Central kind of findings.
Yes. Yeah, this patient should be kept under follow-up and see how, like, whether it is recurring and what is the pattern of nystagmus that happens during the recurrence.
Absolutely, absolutely. See, I see some of our friends here. I see Dr. Voda here. Ma'am.
Hello, Dr. Srinivas.
Yes, sir.
Sir, his MRI, I got it done. It is perfectly normal.
MRI is normal, so that is one more information. That is one more.
Looking at the nodular, floccular, everything is perfectly normal. There is no loop. CV junction is perfectly normal.
Okay, so cerebellar nodulus is normal. There is no loop. There is and the craniovertebral junction is normal. Three things are normal.
Everything is normal. There is nothing to explain.
Yeah. So, excellent, sir. So there are three things that we generally look for in this. We look at the posterior cranial fossa, especially the posterior cranial fossa, and then the craniovertebral junction we look at in these kind of patients. We specifically look at the cerebellar nodulus in patients with positional vertigo, especially the apogeotropic variety. And of course, we look for vascular loops. Nowadays, we have started looking more aggressively at vascular loops, and all the three have been ruled out. And I know with what meticulousness Dr. Sandeep Sharma gets the MRI done. Okay, the radiologist does a special reporting for him because he knows what all questions he's going to ask. So that is how it is done. So when they say that nothing has been found, then nothing has been found. Okay, I see Dr. Voda here. I see Dr. Avinash Bijlani here. Anybody wants to join in and add a comment, please do.
We'll keep a check and we'll again discuss after a few months.
Absolutely, absolutely. You can give us a follow up, and then in one of the Vertigo grand rounds, if something new comes up, we will always tell you. Okay. So then one more thing here. Yeah. I saw Dr. Bijlani was here.
Hello, sir.
Sir. Yes, sir.
Well, very well presented by Dr. Sandeep Sharma and very well evaluated by the panelists and you. A wonderful case to reflect upon, and this will teach us a lot for the future.
Yeah.
And one more thing I would just like to point out is that I have had a couple of patients, and one was just 2 days back, and she was a case of left lateral geotropic variant of PPPV.
Okay, sir.
Her symptoms were worst on lying down straight supine as compared to right lateral or left lateral.
Exactly like this patient.
Exactly. And moreover, her nystagmus was much more intense in the sit to supine position. And the sit to supine position definitely pointed towards the side of the lesion or the canal involved. Whereas when it came to the lateral positions, the intensity of the nystagmus and the duration of the nystagmus were literally, very unconclusive. And the only indicators I was having was the head pitch and the sit to supine test. So these also have their value.
Exactly, sir.
Coming to the fact that this patient presented with also a hyperventilation induced nystagmus, that is definitely mind-boggling.
Yes, sir. But I think nowadays we have started noticing some patients. Okay. In fact, after Dr. Sandeep Sharma shared this patient with me, one more patient I saw with a hyperventilation-induced nystagmus in a lateral canal BPP.
And subjective visual vertical is definitely bound to be deranged in these patients because definitely there is a mismatch between the two sides.
Yes.
So in fact, if we start doing a subjective visual vertical and as well as hyperventilation test on these patients, I think as a routine, as a practice,
we'll become much more. Many more.
Yeah, we'll become much more wiser, and probably these would become the standard kind of derangements that these patients definitely show. Maybe most of them show, but we are not aware.
Possible, and that is actually an opportunity lost, because this gives an opportunity for us to actually study the neural mechanism, the central neural mechanism.
True. Like you mentioned, the leaky integrator.
Exactly, sir.
Definitely, yes, there is something going wrong centrally also when you have a peripheral vestibular lesion.
Yes.
And BPPV also is, albeit temporary,
yes,
but it is definitely an alteration in the vestibular setup.
Absolutely, sir. Absolutely. Dr. Devi Prasan, I can see. Sir, thanks for joining.
Thank you, sir. Thank you.
How's Oman?
Yes, good, sir. Oman is good.
Yes, sir. You have something to add?
Sir, this is a very interesting and a confusing case, to be frank, because we are getting so many findings. Findings of central vertigo and findings of peripheral vertigo both.
Yes, sir.
Of course, you are right. You rightly said we are evaluating patients even with BPPV with so many investigations, and newer types of findings are coming up.
Absolutely, sir.
In case of BPPV, so it may be a case of BPPV also, but
yes,
it may be a coexisting BPPV along with the central pathology.
Yes, sir. So at least MRI wise, there is no central pathology. So let us see, and he is going to give the follow-up. Okay, Dr. Sandeep Sharma has promised to keep a strong follow-up and keep us informed. Anything new comes up in one of the grand rounds, we will tell that. Okay. I can see Dr. George Bakarna. Sir, you have something to say? Dr. Sonali Pandit. I don't know, for some reason. Have you muted participants, Abhishek? Nothing like that, no?
No, sir. They can unmute themselves.
They can unmute themselves, right? Okay. Okay, fine. Dr. George is not able to talk. No problem. Thank you, sir.
They can just click on this one, join audio.
That's okay. That's okay. Absolutely no problem. So anybody else wants to say anything about this, please, without any hesitation, unmute yourself and say something. Dr. Abik, any closing remarks? Abik sir, we lost your image. We lost your video. Dr. Dhanya, any closing remarks from your side?
No, sir, it was really an interesting case. Good that it was picked up for the discussion.
Yeah.
So like in future, I'll check the BPPVs to see like how the hyperventilation will look like, and just to see where the other patterns are there.
Maybe this can inspire a multi-center study.
Yes, sir.
Yes. Dr. Abhi, any closing remarks from your side, sir?
No.
Something.
Close follow-up of this patient.
Close follow-up for this patient. Yes, excellent. And maybe you will be doing more evaluation, hyperventilation for all patients.
I would.
Yeah, excellent. Okay. So with that, I think somebody, Dr. Rajkumari Khatri has raised your hand. Please, you can unmute yourself.
Good evening, everyone. I want to say that just rule out because of the hyperventilation any psychogenic factor, because the patient with migraine and history of psychogenic factor may lead to the change in, because sometimes the MRI may not pick up the functional things, no? Structural changes we can make out with the MRI, but not the organic.
But ma'am, will you consider
because psychogenic factor leading to the hyperventilation can bring about the change, because psychology can do anything. Psychology will affect the central.
I
So I'll
understand that.
make an understand, because many of the patients who have the central vertigo, which you say, have the functional attitude in that also, because of the long-term standing. How much is the history of the vertigo? It is also important, because it may lead to the psychogenic effect.
Psychogenic dizziness is okay with hyperventilation, but
Yes. So that hyperventilation long time will give rise to the change in the circuit, no?
Yeah, that is there. It
Yeah,
will
we
always
can
cause
investigate on that aspect also, because long-term hysteria and psychogenic effect give rise to the change. Patient will always walk like an unstable gait. I've seen many of the patients with central vertigo. There is no cause in MRI, but still they are having the vertigo throughout the life.
that I understand, but here this was not as a hyperventilation, as it was done as a test, where Dr. Sandeep Sharma made the patient hyperventilated in front of him, and rather than patient complaining dizziness, we got an objective finding, which is nystagmus. So can we explain actual nystagmus developing based on psychogenic factors? Dizziness, yes, dizziness I completely agree.
Nystagmus we can't explain.
Nystagmus we can't explain. That's okay. Yes. And this was done as a test. I completely agree with you that there are a lot of hyperventilating patients who always feel that they are walking on wool, so that kind of feeling. Yes.
Yes.
Yes. So I think with that, this was I personally enjoyed this particular grand rounds. I again thank Dr. Sandeep Sharma for bringing about this wonderful case. I'm sure that there is more and more cases that all of you will be watching. With this, I request all of you, if you have any nice case to present and ask questions of. If you have a nice case to ask questions from whatever, anything that is troubling all of us, okay, there is absolutely no fear of judgment. We don't judge one another here, okay, because by mistakes we grow, by mistakes we improve. Okay, so that is how we do. Okay, for questions that we did not have answers 5 years ago, we are having answers now. So, and that is how the science progresses, and when science progresses, the humanity benefits. So with all these things, I want to again thank Dr. Sandeep for bringing this case, Dr. Abhik for joining in and bringing his thoughts and insights, and Dr. Dhanya for bringing her thoughts and insights, and all the participants who contributed, Dr. Rajkumari, Dr. Avinash Bijlani, all of you. So thank you all. Thank you again, and see you again in the Balance Con, and after post. Okay. So we'll see you again in the Balance Con and in the next Vertigo Grand Rounds in the next month. Thank you all.